My name is Jessica Robinson-Papp. I'm a neurologist here at Mount Sinai. I work here predominantly in neuropathy, and my research interest is mostly in HIV-associated neuropathy, although clinically we see a lot of diabetic neuropathy as well. I work in the EMG lab here, and I'm the director of the Autonomic lab as well. So I'm going to be talking to you about the diagnosis and management of diabetic peripheral neuropathy. So when we think about neuropathy, a lot of times we start by thinking about pain, because that's one of the symptoms that our patients complain about most. And if we think about pain in general, not just due to neuropathy, it really is a huge chronic problem in primary care. So about 60% of adult patients will report chronic pain to their primary care provider at some point during their care. And about 1 in 5 of these patients have some sort of pain that they attribute to nerves, some kind of neuropathic pain. The localizations of pain in these patients are what you might imagine them to be. The back is a very common source of pain. Joint pain is probably the most common. And then other areas like limb muscles, abdominal pain, and chest pain are somewhat less common. Neuropathic pain can be due to different reasons. The most common forms of neuropathic pain in the US are estimated here in this pie chart. Probably back pain is the most common one, and this often can be just axial back pain where it's mostly muscular, or it can have a neuropathic quality when the nerve roots are involved, and then patients may complain of shooting, tingling, burning type pain. As you can see here, diabetic neuropathy pain is probably the second most common, followed shortly thereafter by postherpetic neuralgia. Other causes include spinal cord injury, complex regional pain syndrome, and other less frequent complications like multiple sclerosis, stroke, HIV. So neuropathy is very common in diabetes, and the prevalence estimates of neuropathy depend a lot on the study. It depends on the population under study, so when they're population-based studies coming from the community, the rates tend to be lower. When they're taken from tertiary care centers, then the prevalence estimates are higher. Also, it depends on what you include. Some studies have included patients who were asymptomatic with the symptomatic patients, and then those estimates are higher. And then also it seems that the studies that are older have slightly higher prevalence estimates. But here are a few of the prevalence estimates that are in some of the larger studies. So one study, which was a population-based study, showed 6% of patients at the time of their diabetes diagnosis had neuropathy. And then when they were followed forward in 10 years, 20% had neuropathy at that time. In a population that was a little bit more advanced when they were studied at 8 years, this population had a prevalence of 26.4%. In the Rochester Diabetic study, which is a large study of diabetes, about half of all patients had neuropathy. That study also included asymptomatic patients, and so that's why that's a little bit higher. So in the Rochester Diabetic study, this was a study of 380 diabetics living in the community around Rochester. They found that if they looked at just symptomatic neuropathy, there was a prevalence of about 15%. And there were different kinds of neuropathy observed in this cohort. So the most common was a distal symmetric polyneuropathy. The second most common was carpal tunnel, and then autonomic neuropathy, and then other forms of neuropathy were less common. And we'll talk about each of these 3 forms in more detail. So what are polyneuropathies? Well, polyneuropathies are the ones that we sort of think of as being neuropathy. When our patient comes in complaining that their feet are numb and tingling and burning, that's a polyneuropathy. So it's usually distal predominant. It can be insensate, where the problem is mostly that there's sensory loss, or it can be painful, where the predominant problem is the pain. Sometimes patients can have something called a small fiber neuropathy, which is just a painful neuropathy that does not have significant sensory loss. Carpal tunnel syndrome often presents with symptoms in the hands, and there are other focal mononeuropathies. So this is a syndrome where there's just one particular nerve involved. And then autonomic neuropathy is when the nerves that are innervating all the internal organs, like the heart, the blood vessels, the gut, the urinary system, when those nerves are involved, and then patients can have symptoms referable to all of those different organ systems. Here are some examples of some rarer neuropathies. There's polyradiculoneuropathy. This is every now and again seen in diabetics, where they'll have this sort of shooting kind of pain coming from the back across one side of the thorax, or maybe into one arm or one leg. It sounds like a radiculopathy that could be caused by a structural lesion, but no structural lesion is seen. It can also be confused with a zoster-like pain. Sometimes that kind of pain can come on right before someone gets shingles, but this can occur just from diabetes alone, and so it's something to be aware of. They can also get proximal neuropathies, The classic one here is a diabetic amyotrophy, and that presents with groin pain and usually weakness in the proximal lower extremity on the same side. And then more rarely, they can present with mononeuropathy multiplex, which is where they have involvement of different nerves in different limbs. So here's just a pictorial example of some of these different kinds of neuropathies that we're mentioning. This is the one that we'll spend the most time focusing on, polyneuropathy. Mononeuropathies, the example that we'll spend the most time focusing on is carpal tunnel syndrome. And then this is a plexopathy, which is similar to that diabetic amyotrophy that I mentioned. And this is an example of mononeuropathy multiplex. So the person might have one nerve affected over here, and then another nerve affected over here, and then maybe one in a different limb. So what are the clinical manifestations of our most common form of neuropathy, which is the distal symmetric polyneuropathy? So usually it starts most distally in the body, and the reason for that is that the nerve cells that these nerves originate from are all the way up in or near the spinal cord. And then there's one long axon that travels all the way distally into the hands and the feet. So that axon is really metabolically dependent on its cell body, which is all the way back up by the spinal cord. So it makes sense that when the cell starts to dysfunction, it's the most distal part of the cell that starts to have problems first. And so that's why clinically we see first symptoms in the feet. Often patients will complain of symptoms in the balls of the feet or in the toes. And then if the neuropathy progresses, then the symptoms may progress up the leg over time. A good rule of thumb is that often by the time that the symptoms get up to the knees, then they're starting to have symptoms in the hands as well, because that's about the same length from the cell body down to the fingertips. So what are some of the symptoms? Well, patients often will complain of pain, and they'll describe the pain in a lot of different ways. They may say it's burning pain, shooting pain, stabbing pain. They may note that it's worsened by activity. They may report hyperalgesia, which is that they're very sensitive to the touch. They don't want the feet touched. They feel like if the sheets are touching their feet at night, then that's painful. Sometimes they complain of a pins and needles sensation, which we will refer to as paresthesias. And a lot of the times they'll complain of numbness, and people mean different things when they say numbness. Sometimes they actually mean the loss of sensation, and sometimes they actually mean a more positive symptom of sort of a dead feeling, an annoying kind of cold numbness. So all of those things are very typical symptoms of neuropathy. Sometimes people will actually have a little bit of weakness in the feet as well. It's usually not too clinically apparent to the patient, but often if you examine the feet, you can see wasting in the small muscles in the feet. And what that looks like is that the tendons appear more prominent and the feet look very skinny. People can also complain of trouble with balance because they don't have good sensation in their feet. And if they do have this problem, they'll often note that it's worse at night because when the lights are off, you don't have as much visual input to try and compensate for this sensory loss. So when we examine a patient with neuropathy, what do we see? Well, we test their ankle reflexes, first of all, and the way we do that is by tapping with a reflex hammer on the back of the ankle. And a normal response to this is for the foot to plantar flex down like this. It may be normal in patients over the age of 65 to have an absent ankle reflex, even if they don't have neuropathy. So if they're an older patient, then we may sort of let that go as part of our exam. And then they will also have signs of decreased sensation in the feet or in the hands. And we test different forms of sensation. Vibration sensation is tested by striking a tuning fork and placing it on the toe and asking the patient if they feel it, and then doing it at different degrees and seeing what the smallest vibration that they can feel is. We test sensation of sharp, so that can be done with a clean disposable pin, or the way I do it in the clinic, which is just a little bit simpler, is we have those small cotton swabs with the wooden sticks, so I break that off and see if it's pointy, and it feels pointy on the patient. And in very advanced cases, they can sometimes actually have loss of proprioception, which is where if you move the toe up and down, they're unable to tell you which way the toe is moving. So when we encounter a patient with diabetes who has neuropathy, often we'll assume that the cause of the neuropathy is diabetes, and we'll probably be right because that is the most common cause of neuropathy. But it still is important to try and see if there's anything else that might be contributing to the neuropathy that is potentially treatable. So we like to take a thorough medical history to make sure that there isn't any coexisting liver or kidney or autoimmune diseases or cancer. Sometimes neuropathies can occur as part of a paraneoplastic syndrome. We want to take a good social history. Certainly alcoholism is a common cause of neuropathy. There are sometimes nutritional deficits in people, even in the setting of obesity or not clear nutritional deficits. We sometimes will see vitamin B12 low in people who we would never guess would have low vitamin levels, and we think it's probably due to just a very poor quality of diet. We also want to inquire about HIV risk factors, because that's another cause of neuropathy. Reviewing the medication list is very important because there are lots of common, potentially neurotoxic medications. Neuropathy. Some forms of neuropathy can run in families. So in my patients, I do a very basic screen for everyone, and these are the things that are recommended by the American Academy of Neurology for basic neuropathy screening. Obviously, you would screen the patient for diabetes if you didn't know that they were diabetic already. We want to do a comprehensive metabolic panel. We want to screen their thyroid function, look for vitamin B12 deficiency, and then we want to do some test to look for monoclonal gammopathy, either a serum protein electrophoresis or an immunofixation, because some either MGUS or hematologic malignancies are fairly common in the general population and are a significant cause of neuropathy. Depending on the patient, the risk factors, the age, we may want to do some additional screening blood work to look for other causes, but these are sort of indicated in more specialized cases. Here's a list of some potentially neurotoxic medications. Obviously, the chemotherapeutic agents are included there. Some of the old antiretrovirals that we use for HIV were there as well. So what do we do with our patient who we suspect has neuropathy in the clinic, and we do our neurologic exam and it shows neuropathy? Do they need any other additional tests other than excluding other causes with blood work? Well, for my patients, when they're a very kind of classic distal symmetric polyneuropathy and their exam looks that way, I don't necessarily order other diagnostic tests. If there's something unusual about the neuropathy, then I may do that to characterize it better, and the tests that are available are these. So the most common one that we use are nerve conduction studies and EMG, and I'll show you a little bit about that. There are also skin biopsies that we can take to actually look at the nerve fibers in the skin. We can do tests of the autonomic nervous system, and we can do quantitative sensory testing, but this is more done in research practices. So what do some of these tests look like? This is an example of a nerve conduction study that's being performed on a patient. This is similar to what would be done also to look for carpal tunnel syndrome. Here, we're stimulating the median nerve at the wrist, and we're recording from a muscle the abductor pollicis brevis here in the hand. And what it looks like on our computer is we'll get a waveform like this when we stimulate at the wrist, and then we'll stimulate the nerve higher up, and we'll get another waveform. And we'll look at the size of the waveform and how fast it's occurring on the screen, and that'll tell us something about their neuropathy. This is an example here of a skin biopsy specimen. These are taken just as a very small punch biopsy, very similar to what a dermatologist would do, except the skin is treated and stained in a special way, and then we can count the number of small nerve fibers up in the skin and compare them to normal values. So this is a normal patient here who has all these nerve fibers, and this is a patient who had HIV-associated small fiber neuropathy, and they have almost no fibers left in the skin at all. This can be an important diagnostic test when some of the other tests might be negative and you really are looking for a definitive diagnosis. We don't do this too often, though. It's minimally invasive, but it is still a small biopsy. So how do we approach treatment of the patient with distal symmetric polyneuropathy? So we want to try and find the underlying cause, which in our patients would be diabetes most of the time, and also try and see if there are other things that could be ameliorated that might be contributing to the neuropathy, and treat them if it's possible. For example, a B12 deficiency, or if there's a substance abuse problem and an intervention there. And in the absence of all those things, then what we want to do is to try and reduce their pain. And the first thing that we have to do is to try and figure out what is the symptom that's bothering them the most. If it's actually the loss of sensation that's bothering them, then trying to give them neuropathic pain agents is not going to be helpful, because there's nothing we can do right now to really restore their sensory function. So when people say numbness, that's why I spend a lot of time trying to get out what they actually mean by that. If it's loss of sensation, then I'm not going to start neuropathic pain medications. If it's actually sort of an uncomfortable sensation, maybe a paresthesia, but they're using the word numbness, then that might be something that would be amenable to treatment. So what kind of treatments do we have available? Well, in order to prevent the progression of neuropathy, glycemic control is very important. This is an old study, but it was in the New England Journal of Medicine, showing that intensive glycemic control does help reduce neuropathy. And this was actually reviewed recently, the data about this, to see whether this recommendation still holds. And basically, the take-home message here is that while intensive glycemic control does help prevent worsening of neuropathy, it has to be weighed against the patient's general condition. And it's acknowledged that very intensive glycemic control can increase the risk of hypoglycemic episodes. So basically, you have to take the whole patient into account before recommending this. There are some non-pharmacological treatments for neuropathic pain that, for the most part, have not been studied rigorously in clinical trials, but sometimes can be very helpful anecdotally to patients. Here are some strategies for that. Relaxation therapy, meditation, physical therapy, acupuncture have all been successful for some of our patients. The more standard treatments that we use are usually pharmacologic, and this is a timeline of some of the treatments that we have available and which ones are FDA approved. Duloxetine and pregabalin are the two that are FDA approved for diabetic neuropathic pain. Some of the other agents are approved for other forms of neuropathic pain. And so when we think about treating neuropathic pain, usually the pain agents will fall into one of these four categories: the anticonvulsants, the antidepressants, the topicals, and then the non-specific analgesics like opioids. And we try to think about the safety and tolerability of each of these agents when we choose one for our patient. And then we also try to think about what is a reasonable expectation for therapy. Neuropathic pain is very difficult to treat. In some of the clinical trials, a good result is usually considered a 50% improvement in about 50% of the patients. So if you're in the clinic, that's a little less than you would like. I mean, you're not making your patients 100% better. So it's important to manage expectations about neuropathic pain without becoming so glum to the point that you're effectively making your medication less effective by telling the patient it's not going to work. We call that a nocebo effect, when you're so depressed about your own medications that you basically make them ineffective. So we try to balance that. So the anticonvulsants are probably the things that are used the most frequently. Gabapentin is an oldie but goodie. It's commonly used for a bunch of reasons. It's generic now, so it's fairly inexpensive. It can be dosed at a very wide range of doses. So you can start a patient who is potentially very sensitive to side effects of medication, or elderly, or concerned about a medication. It can be started very, very low and then titrated up to higher doses. Some patients who are very concerned that they're going to have a side effect of a medication, I will give them 100 milligrams of gabapentin at night, which is a homeopathic dose, but just saying, we're going to give you this medication, we're going to let your body get used to it. It's probably not going to help you at this dose, but we'll slowly increase it so that you have time to get used to it. And sometimes that can make it more acceptable to someone who's very concerned. And then in patients who have a lot of neuropathic pain, we have patients on doses as high as like 1,200 3 times a day. So there's a very wide range of dosing. It doesn't interact with other medications. It has relatively few side effects. The main side effects, some people will experience a little peripheral edema or weight gain from it, a little bit of sedation, which can usually be ameliorated by starting quite low. There's a new extended release form that was recently FDA approved, which is called Release, and that's given once a day. It was FDA approved for post-herpetic neuralgia. Pregabalin is extremely similar to gabapentin. Some would say that pregabalin was developed purely for the reason that gabapentin was going off patent. But some patients, for whatever reason, will do better on pregabalin than on Neurontin. So we'll switch people back and forth depending. One advantage is that pregabalin is dosed twice a day instead of 3 times a day, so that's a little bit easier for some patients. But both of these are fairly similar. And these are usually my first go-to medications just because they're very simple to give. They have few side effects, and people tolerate them very well. This is just a picture from one of the clinical trials of gabapentin showing its efficacy, and another one for pregabalin. So the other main class of oral medications that we use are the antidepressants. And there are sort of 2 subclasses within there that are useful: the tricyclic antidepressants and the SNRIs, which are mixed serotonin norepinephrine reuptake inhibitors. So the tricyclic antidepressants are very old drugs. They've been around since the 1960s. They have a lot of side effects. They're sort of what we call dirty drugs, but they also can be really effective in some patients. So we still use them quite a bit. The SNRIs are a newer class of agent. The main one is duloxetine, which is FDA approved for the treatment of diabetic neuropathic pain. Venlafaxine is an older SNRI. which we also use sometimes. The most common side effect of these medications is nausea. Duloxetine in particular can cause a lot of nausea in the first week of treatment. It usually gets better with time though, so if you start with a low dose like 20 or 30 milligrams and warn your patient that this might happen and that it'll likely get better, then they usually can get through that first week of nausea and then be okay. So what are some of the adverse effects of the tricyclic antidepressants like amitriptyline and nortriptyline? There are a lot of them. They have a lot of anticholinergic side effects, so people have dry mouth, dry eyes, they can feel sedated, constipated. You have to be very careful if people have any kind of urinary symptoms to begin with, like BPH, because it can cause urinary hesitancy. You have to be really careful in elderly patients as well. If there's any kind of cognitive problem, then we're really careful with these. And if there's also significant cardiovascular disease, you have to be careful. The patients that I would use this in the most would be, for example, younger patients who are a little bit more robust, who may be having a lot of pain at night. Some people, they can, if they're busy during the day, they're working, they don't notice their pain a lot because they're distracted. And then when they get home and they try to relax, all of a sudden their feet are on fire and they notice them, and then they can't sleep. And so then we can kind of use the side effect of the drowsiness to try and put them to sleep, and then also only dose them at night. So those are the patients that I usually start this in. I also will use this one more in patients who have comorbid migraine, because it's also a really good migraine medication. So often the starting dose will be something like, if you're being cautious, 10 milligrams at night. If you have a sort of a more robust patient who doesn't usually have a lot of side effects, then you can try 25 milligrams at night. Sometimes I'm surprised with these. Like I have one patient who gets side effects from everything. And what does she tolerate? She tolerates amitriptyline 25 milligrams twice a day, which would never have been my first guess. I would guess that she'd be on the floor asleep with that, but that's what works for her. So a lot of this is a trial and error game, trying to find the right combination of drugs for your patient. So here's some old data about efficacy of tricyclics and of duloxetine, which I'll just sort of run through quickly. What do we have for topical treatments? We have two main topical treatments, the lidocaine patch and the high-dose capsaicin patch. The lidocaine patch is FDA approved for postherpetic neuralgia. It's basically just a topical anesthetic patch that people will put on their thorax in postherpetic neuralgia. It's pretty cumbersome if your neuropathy is in your feet because it's like a plastic patch, and to put it on the feet is a little bit annoying. I'll sometimes give people topical anesthetic creams like Emla to use when their neuropathy is very bad. There's absolutely zero data that that's helpful, but some patients anecdotally find it helpful. The high-dose capsaicin patch is a medication that we were pretty excited about. It's capsaicin, which is basically the spicy stuff in chili peppers at a very high concentrated dose. And it is now FDA approved for postherpetic neuralgia. We can sometimes, it depends on the insurance. So because it's only approved for postherpetic neuralgia, many insurances will not pay for it for an off-label treatment. So sometimes it's really helpful to put it on patients' feet. It's a one-time treatment that you do in the office, and then the efficacy can last up to 3 months. So that's very attractive to a lot of patients who don't want to be on a daily medication. But it is off-label for diabetic neuropathy, so whether we can get it or not depends on the individual patient's insurance. So sometimes we have to combine drugs together to get good efficacy. As we said, this is a very difficult condition to treat, so sometimes patients will need more than one medication. And sometimes that allows patients to actually be on lower doses of individual medications. And there was one good study that showed that quite nicely. This was published in the New England Journal of Medicine in 2005, and they did a combination. It was kind of a complicated study. They had a neat placebo control. They used a benzodiazepine as the placebo so that patients would feel like they were getting something and feel slightly sedated, and to try and blind it better. And then they had a gabapentin arm, a long-acting morphine arm, and then a combination arm, and they showed that the combination was better effective than any medication alone, and also allowed for lower doses of both medications. So in the interest of time, I'm just going to speak very briefly about carpal tunnel syndrome and 2 words about autonomic neuropathy. So here's a very classic carpal tunnel patient. So patient presents with complaints of pain in the arm and the hand. The pain has been present for the past few months, recently worse. It wakes them up at night. When they get up at night, they have to shake out the arm like this to make the pain go away or run it under water, and then it resolves. Sometimes it might feel so bad that it's not actually in the hand, but going all the way up to the shoulder and moving around provides some relief. So this is the most common entrapment neuropathy. It's very common in the general population and more common in patients who have some kind of risk for neuropathy like diabetes. It's a little more common in women. It can be bilateral. It's usually worse in the dominant hand, so for most people it's usually in the right hand. The treatment of this is conservative at first. Splinting can be really helpful, so we give people a neutral wrist splint, which has usually a piece of hard plastic here on the inside of the wrist. The purpose of that is to just keep the wrist in a neutral position, neither too much in this direction nor too much in this direction. If it's too bothersome to the patient, we tell them to just wear it at night, because at nighttime is really the time when your hand will get into more sorts of funny positions without you noticing it. If that's not helpful, then local injections, NSAIDs, neuropathic pain medication, occupational therapy, and ultimately surgery can be the treatment. And then just a few words about autonomic neuropathy. So this can be very difficult to diagnose because it can affect multiple different organ systems and be really nonspecific and sound just like disease of any end organ. So this is a simple questionnaire that was developed to assess autonomic symptoms. So one common symptom of autonomic neuropathy is orthostatic dizziness, so lightheadedness upon standing, which is due to orthostatic hypotension because the autonomic nerves are not sufficiently constricting blood vessels in the periphery or speeding up the heart rate to try and combat it. People may have dry eyes or dry mouth. They may notice vasomotor changes, so blue hands or cold hands and feet. They may notice changes in sweating and difficulty with nausea, vomiting, or bloating after a meal. Diarrhea and alternating constipation can also be involved, and then urinary dysfunction and sexual dysfunction are also problems. The way this is diagnosed is with an autonomic reflex screen. So basically, we'll bring people into the autonomic laboratory, we'll attach them to this continuous blood pressure monitor on the finger, we'll measure a 3-lead EKG, basically just to get rate, and then we'll measure their breathing, and we'll subject them to a bunch of different physiologic stressors to try and see how their autonomic nervous system responds. The two that are the most common are the tilt table test, so we want to just monitor their blood pressure while they go into an upright position to make sure they're not orthostatic. And then we also measure sinus arrhythmia. So we want to make sure that while they're taking these deep, slow breaths, their heart rate is going up and down with the deep, slow breaths. So that's normal. In a patient who has neuropathy around the heart of the vagus nerve, this will be more flat, and that's been shown to be a risk factor for increased cardiovascular morbidity and mortality in diabetes. Neuropathy is common in diabetes. Distal symmetric polyneuropathy, which is sensory predominant, is the most common form of it. Other forms include carpal tunnel syndrome and autonomic neuropathy, as well as small fiber neuropathy, which can present just with pain and paresthesias in the feet with a relatively normal neurologic exam. Neuropathic pain is often the most bothersome symptom of diabetic peripheral neuropathy, and pharmacologic options include the anticonvulsants, the antidepressants, topical analgesics, and non-specific analgesics such as the opioids. Sometimes these must be used in combination for the greatest effect. And I think that's the end. Thank you.